Welcome everyone to today's webinar, Preventing Falls in At-Risk Older Adults. Today's webinar is facilitated by the Loop Fall Prevention Community of Practice. My name is Michelle Dukeman. I am the Knowledge Translation Coordinator for the Fall Prevention Program at Parachute. Parachute sponsors the Fall Prevention Communities of Practice Loop and Loop Junior, along with the annual Fall Prevention Month campaign. Before we begin, we'd like to start today's presentation with a land acknowledgement. Today, we respectfully acknowledge the land on which we live and work as the traditional, ancestral, and unceded territory of the Indigenous people, Canada's First Nation, Inuit, and Métis people, whose presence reaches back to ancestral time. We respect and affirm the inherent rights and title of Indigenous people of Canada and declare our respect of Indigenous elders, past, present, and future. I would like to ask everyone to take a moment to themselves to acknowledge the land where they currently reside. Next, I'll cover a few housekeeping items. During the webinar, if you have questions about the technology, please type them into the chat box. My colleague Marguerite will be monitoring this. But if you have questions specifically for our presenter about the webinar, please submit them through the Q&A box. They're going to be answered at the end of the webinar, and you'll only be able to view questions you have asked and not questions posed by others. The webinar is being recorded, and a YouTube link will be sent to all participants in about a week, along with a link to the presentation slides. If you can view the previous webinar recordings as well, simply head over to the webinar page on Loop and click on archived webinars, or you can visit Loop's YouTube channel. Now, I'd like to introduce our presenter, Dr. Teresa Liu-Ambrose. Teresa is a physical therapist and a Canada Research Chair at the University of British Columbia, their Department of Physical Therapy. She directs the Aging, Mobility, and Cognitive Health Laboratory, as well as the Vancouver General Hospital's Falls Prevention Clinic. Her research focuses on understanding the role of exercise in promoting cognitive and mobility outcomes in older adults. Her research expertise is in randomized control trials, exercise prescription for older adults, cognitive neuroscience, and mobility aging. Her research findings have been implemented into clinical practice, community programs, and influenced international practice guidelines to promote healthy aging. For a complete bio on our presenter, please take a look at the Loop event calendar. So without further ado, please take it away, Teresa. I'm going to now let you share your slides.
Thanks, Michelle, for that kind introduction, and also thank you for inviting me. And thanks everyone for taking the time to be here today. So I'm just going to take a second to pull up my slide and to share. Sorry, just give me one sec. Okay, and I just want to, I guess, Michelle, if you can just confirm that I'm projecting the correct slide or screen.
I'm not seeing a slide.
Oh, okay. That's odd.
Maybe give it another go.
Okay.
It's not showing that you're sharing your screen at all.
Oh, okay. Maybe that's why. Share screen. Oh, I see. I see what I did. Okay, never mind. Hopefully this works now.
Yep, seeing the slide itself. Perfect.
Right. Okay. So for today, I'd like to talk a little bit about preventing falls in at-risk older adults. But before I begin, I also just want to acknowledge that for myself, that the land by which I'm currently am working and residing is the traditional, ancestral, and the unceded territory of the Musqueam people. In terms of today's sort of conversation, I have structured it whereby I'll start with a sort of a background with a slightly different sort of, I guess, expansion as to how we view falls prevention in older adults in general, and then really kind of delve into one of the studies that we've conducted at UBC in at-risk older adults, and then taking those findings as well as those of the literature in terms of potential implications. In terms of learning objectives, my hope is that at the end of the presentation that all of us will be able to explain the current or expanded view of how exercise may prevent falls in older adults, identify common tests of executive functions, and potentially, understand its relevance within the context of screening for falls risk. And lastly, to identify ways to potentially augment traditional exercise programs to target cognitive and brain risk factors for falls. So to begin, obviously, we all recognize that falls among seniors is a major health issue, and that in terms of key intrinsic risk factors for non-syncopal falls includes one's physical functions, such as their muscle strength, their ability to balance, as well as their mobility, such as how quickly they can walk at their usual gait speed. But also within the last, I would say, 15 years now, there is increased recognition that the central nervous system or any sort of impairment at the cognitive level can also increase one's for falls. When I say reduced cognitive function, I really do want to emphasize I'm not referring to, more sort of a progressive deterioration such as dementia, but more even mild changes in cognition that is associated with aging. And when it comes to reduced cognitive function, the cognitive domain of executive functions have really come up within the literature and within research as sort of the primary cognitive domain that seems most relevant to one's risk for falls. And so I just want to take a second and expand on what we mean by executive functions. So these are higher cognitive abilities that really allow us to plan, to make good decisions, and to multitask as well. And we know from research and from actual clinical observations that intact executive functions are critical for one's ability to actually adhere to recommendations and to adopt positive lifestyle behavior. So it really has huge relevance as to how people can adhere to what we prescribe to them when it comes to falls prevention. Executive functions play a huge role in one's functional independence. It really does tie into the ability to, let's say, complete finances, to cook, to plan, again, their daily lives. And we do know that there's a tight correlation between one's executive functions and their mobility, specifically their gait speed and the risk for falls. Now, when it comes to cognition and mobility, they are tightly correlated in the sense that we do often observe that among older adults that impaired mobility and impaired cognitive function seems to go together. Not always, but certainly very commonly they do. And it is recognized that they likely coexist because they have shared common pathophysiology. And there's actually a number of sort of underlying mechanisms as to why these two components coexist. But some of the key ones I want to highlight today largely reside within the brain, and they include cerebral small vessel disease, amyloid deposition, which we often associate with Alzheimer's disease, but actually research shows that amyloid deposition also increases the risk for falls, and hippocampal volume, which is a key structure for memory. But again, research have also indicated it plays a role in one's mobility. And when it comes to preventing falls, again, exercise has been really recognized as a key strategy to prevent falls. And here I have a diagram really emphasizing, I think, more so the expansion as to how we view exercise in terms of falls prevention. So I think traditionally we've always thought of exercise and how it prevents falls is by sort of promoting the physical aspects of the individual. So when you prescribe exercise, you improve one's muscle strength, you improve their balance, and potentially even their coordination. But now, again, within the context of what we know in terms of the multitude benefits of exercise, is that it also has significant impact on one's cognitive function and even brain health. And again, with the increased understanding of the role of the sort of the central nervous system in our mobility and falls prevention, the current view now is expanding towards how can we better understand the role of cognitive function in relation to the effect of exercise and its role in falls prevention. And just very briefly, in terms of what we know in regards to exercise and cognitive function, the evidence does suggest that it has benefits to the degree that it's been publicly recommended and agreed upon that regular exercise is beneficial for brain function and reduces the risk for dementia. And also multitude of systematic reviews and meta-analyses also highlight that various types of exercise training, so whether it's aerobic exercise resistance training or multi-component, which would include, different types of exercise training, as well as Tai Chi and yoga, can have benefits for cognitive function in older adults. So I just wanted to highlight this to sort of really show that, the benefits of exercise is beyond the physical aspects. In addition, we know from the neuroscience research that exercise in itself has direct impact on the brain. So through advanced neuroimaging and through trials of exercise, our own group have shown that exercise can actually reduce the progression of white matter lesions, which is a hallmark of cerebral small vessel disease. Cerebral small vessel disease is a common pathology among older adults, typically clinically silent, but at the same time, we know one of its key consequences is increased falls, as well as increased risk for dementia. Research have also shown that targeted exercise training can improve hippocampal volume, again, a structure that's typically sensitive to aging effects, whereby after the age of 50, it reduces in volume by upwards of 2% per year. And what research shows is that exercise can actually maintain or actually improve the volume over time. And the significance of this particular finding in relation to falls is, again, there has actually been growing research to show that structures such as the hippocampal volume has an important role in in our ability to move, as well as to move safely. And lastly, as I already highlighted in the prior slide, is that we do know that exercise promotes cognitive function, and specifically within the domain of executive functions. So again, traditionally, we have viewed exercise as a strategy to reduce falls, but I think primarily thinking about its benefits for the physical performance aspects, again, muscle strength, balance, etc. But now with a current understanding and appreciation of the role of the central nervous system, where the view has expanded and really has been more development or more thought and research into how exercise may benefit both cognitive function as well as brain structure, brain function, or integrity of brain tissues that potentially are also contributing to the effect of exercise on falls prevention. And this particular expanded model may be highly relevant to older adults with some degrees of cognitive impairment or have dementia. When individuals have cognitive impairment and dementia, they are at increased risk for falls as compared to community dwelling older adults who do not have any degree of cognitive impairment. And here, data from the Canadian Institute for Health Information clearly show sort of the higher risk for falls and serious falls for those individuals with dementia, whereby a greater proportion of these individuals visit the emergency department because of a fall, whether they live in long-term care or live in their own homes. Now, despite sort of the good amount of evidence for exercise in terms of falls prevention, there's still actually significant knowledge gaps, and primarily within the domain of secondary prevention. So how can we reduce subsequent or recurrent falls among individuals who's already fallen? So these are individuals who we generally categorize as at risk. And part of sort of the lack of good established data reside on a couple of components. One is there's various definition of risk within the literature. So even in the 2018 JAMA paper, which was really a task force report on the role of exercise in preventing falls in older adults, they noted that, when it comes to falls prevention studies using exercise in at-risk older adults, a variety of definitions were used, such that some studies simply used age, so those who are older than 85 as a definition for risk, while other studies may have used a definition of having a single fall in the last 12 months, and then other studies using a little bit more rigorous definitions, such as having a history of fall plus one measurable risk factor, such as a reduced gait speed or reduced time up and go. And believe it or not, as of 2019, and really to date, only 4 trials of exercise have been powerful falls. Powerful falls have been conducted in older adults with a history of falls. So when it comes to, at risk, we actually do know that if you have a history of falls, that really is a excellent indicator that the individual will fall yet again. But to date, there's actually only been 4 trials within this specific population and power sufficiently to detect falls. And notably, 3 of the 4 actually found no significant reduction in falls as a function of the exercise training. And so for the 3 trials that showed non-significant benefit of exercise in reducing subsequent falls, these are the 3. And again, a variety of at-risk individuals. For the first study, those individuals were defined at risk simply by their age of over being 85 years old, while for the Logie paper, they defined individuals at risk as having a single fall in the last 12 months, plus a objective measure of physical risk. So again, depending on whether they had a high time up and go or a slow gait speed. And for the last trial, they simply defined individuals based on a single fall in a 12-month period. And we actually conducted the 4th randomized control trial. In this particular trial, we actually did see benefit for exercise and reducing subsequent falls. So I'll expand more so on this particular trial. So this is a trial that we published back in 2019, and it was designed to primarily assess the efficacy of exercise as a secondary falls prevention strategy. Individuals who were included in this study were 70 years and older, and they had to present to a healthcare provider because of a fall. So it wasn't sufficient that they reported that they had a fall, but they actually had a documented medical visit, either with their GP or at our local emergency department because of a fall. As you can see from the consort flow chart, 344 individuals were included in this particular trial, with equal randomization to either a home-based exercise program, which was the Otago exercise program, which I'm confident many people do know about, but I'll expand on it as well. And the other half received usual care. In terms of the key questions that we wanted to ask within this trial, it was actually 2 very simple questions. One is, can a progressive home-based exercise program reduce subsequent falls in this particular population? And 2 is, how does exercise reduce falls? Is it through improved physical function or potentially through improved cognitive function? And again, believe it or not, very few studies to date have actually addressed the second question, because I think most of us assume it is through physical function. So we measure it and we basically report it, but don't really specifically look at whether either sort of improvements in these measures are actually mediators by which exercise reduces falls. In terms of participants, as I already shared, they were all individuals who sought medical attention, but then were also referred to our falls prevention clinic that's located on the Vancouver General Hospital site. And just to flag that, we know from the literature that those who seek medical attention after a fall certainly are at higher risk for subsequent falls, fractures, and function decline as compared to those who do not seek medical attention after a fall. To be included in this study, in addition to having sought medical attention because of a fall in the last 12 months, they also had to demonstrate risk for future falls based on clinical screening measures, and that included time up and go, the physical performance, the physiological profile assessment, or the short physical performance battery, or having another fall within the last 12 months. In terms of the home-based exercise program, we delivered the Otago exercise program, which really originated from New Zealand and was developed by Claire Robertson and John Campbell. And it is a program designed to be delivered by physical therapists and includes 5 home visits over 6 months. I do want to highlight that it is meant to be a progressive strength and balance training program whereby individuals are prescribed a set of exercises based on their own capacity and to be done 3 times per week. In total, there are 17 exercises that are included in the OEP manual. And basically, the physical therapist with each visit would reassess the exercise programming and individualize and progress as able. In addition to doing the strength and balance retraining exercises, individuals were also recommended to walk twice a week for at least 30 minutes. Now, everybody in this trial received usual care, and I have to emphasize it was very good usual care. So all participants, whether they're in the OEP group or received usual care, so this is the non-OEP group, they essentially received a comprehensive assessment by one of the geriatricians who manned the falls prevention clinic. And the care provided was based on the American Geriatric Society in terms of falls prevention guidelines. So very comprehensive, and just to flag that we did not interfere with any sort of recommendations that would be provided by the geriatrician, but simply documented what was prescribed for all individuals. In terms of the primary outcome, it was falls over 12 months, and they were documented prospectively on monthly calendars. And monthly phone calls were conducted to verify calendar information, also to remind calendars to be returned, and when a fall did occur was to interview regarding the circumstances of falls. In terms of secondary outcomes, we included a fairly comprehensive battery of cognitive or neuropsychological testing, but with a primary focus on assessing the executive functions domain. So we included standardized tests such as the Stroop color word test, which assesses response inhibition, trail making test A and B, which assesses set shifting, verbal digit span forward and backwards, which assesses working memory, and also the digit symbol substitute test, which assesses processing speed. And I highlight the digit symbol substitute test because it is what I would call a really nice clinical test that's feasible. It takes all of 90 seconds. And it really has shown up in multiple research studies as an important metric in terms of its relationship to gait speed as well as to falls. And in the subsequent slide, I'll describe what it is in greater detail. But in addition to the cognitive testing, we also assessed physical falls risk using the physiological profile assessment, which is a tool developed by Stephen Lord, the time up and go test, as well as a short physical performance battery. So just a bit of an expansion on the digit symbol substitute test. It really is a test of sort of a visual search whereby, as you can see on top, there's numbers 1 to 9, and for each number, there's a different symbol that's quite random in nature. And simply for a participant, what they would need to do is really write the correct symbol matching the number as quickly as they can from left to right without skipping any cells. And then after 90 seconds, we simply count the number of correct symbols that match the number. And so while I describe the digit symbol substitute test as a test of processing speed, it really does also tap into visual search, attention, as well as set shifting and psychomotor skills. So it's kind of what I call a kitchen sink test. And perhaps that's why it does seem to show up quite a bit in research when it comes to its contribution to mobility and also in falls. So in terms of participants, again, 344 were randomized, and at trial completion, which is 12 months, 146 completed the OEP arm, and then 150 completed the usual care arm. So the attrition rate actually was pretty reasonable, under 20%. And I just want to take a brief moment to kind of share with you as to who participated in this trial and also to really flag sort of their at-risk status. So first and foremost, I want to highlight that on average, these participants experienced 3 falls prior to steady entry. And as well, approximately 20% of them experienced a fall-related fracture in the 12-month prior, mostly related to the wrist as well as to the spine. I believe there's one that was related to the hip. And then in terms of their cognitive status and physical status, I want to highlight that in terms of their mini mental state examination, it was roughly 28 out of 30, which, it is not impressively low, but in terms of their Montreal Cognitive Assessment, which is a screening tool for mild cognitive impairment, certainly for these participants, they scored well below the 26-point cutoff, suggesting that on average, these individuals had some degree of cognitive impairment and likely, within sort of the mild to moderate degree. And I also want to flag in terms of their short physical performance battery, again, just as a reminder, 12 points is the maximum, whereby anything below 9 indicates increased risk for physical disability as well as mobility disability. Here, our participants scored on average of 8 points, again, indicating their risk for physical disability as well as mobility disability. And then in terms of gait speed, again, the literature suggests that for community dwelling older adults, we really want to see a minimum gait speed of 1.0 meters per second. And again, our participants do score well below that. So again, just highlighting that for this particular study, we captured a group of individuals who are not only physically at risk for mobility disability and probably have some degree of it, but also impaired on the cognitive level as well. So in terms of our results, we found that the OEP did have a significant benefit, whereby compared to the usual care group, those who received the Otago exercise program experienced 36% fewer falls. Notably, we also found that those who were in the Otago exercise program improved their executive functions, specifically as measured by the digit symbol substitute test. And surprisingly, despite the fact that we saw a significant reduction in falls, we saw no significant differences in the physiological profile assessment, the time up and go, or the short physical performance battery. And here's just really a graphical representation of what we saw in terms of the effect of the exercise on falls. So on the vertical axis, we basically are looking at cumulative falls over the 12-month period, which is represented by the horizontal axis, and blue represents those in the Otago exercise program, and orange represents those in the usual care group. And what we clearly see is that over time, that there are greater number of falls experienced by those in the usual care group as compared to the Otago exercise group. And that's represented by our parametric statistics as well. And here is a graphical representation of what we observed in terms of improved processing speed in the Otago exercise group. So on the vertical axis, we have the number of correct responses observed. And on the horizontal axis, we have the 3 measurement points. So baseline, midpoint, and final, representing 12 months. And so what we can see really is that it's almost like sort of at the 6-month mark and onwards, we see an improvement in the Otago exercise participants in terms of completing more correct responses on the digit symbol substitute test as compared to the usual care group. We then also conducted specific statistical analyses to determine what sort of factors contributed or were the underlying pathways by which exercise reduced falls. So in these analyses, we looked at both improved cognitive performance as measured by the digit symbol substitute test, as well as the 3 physical performance measures, so the PPA, the time up and go, and the SPPB. And what we found through statistical testing is that it was improved processing speed that was a significant mediator or pathway by which the Otago exercise program reduced moderately injurious falls. And again, no physical performance measures were actual mediators in the effect of the Otago exercise program on falls. And so the takeaway message is that improved cognition is a potential underlying mechanism or pathway by which exercise reduces falls, but is also probably underappreciated. And when it comes to, the specific measure of the DSST, so again, in this particular study, we found that it improved with Otago exercise training, and that its improvement contributed to the effect of the Otago exercise program on falls. I want to highlight in prior studies, we also showed that the DSST within the context of an observational study whereby we just simply followed people over time, that we found it to be a significant predictor of future falls among older fallers. Specifically, it predicted a greater number of total, indoor, outdoor, and non-injurious falls, and also was a predictor of a greater likelihood of having mild or severe injurious falls. And other researchers have shown that DSST predicts declines in gait speed over 15 or 20 years. So one of the key sort of elephant in the room issues with our trials, certainly I think again, is that we didn't observe any significant improvement in the physical performance metrics, even though we observe a significant reduction in falls. And I also want to highlight that, the degree of reduction we saw, that 36% really aligns with the original Otago exercise program trials that were done in sort of a general community dwelling older adult population. So it does align within the context of what's done previously in other populations, but it's just sort of the whole notion and expectation that if we do see reductions in falls with exercise, we should also see improvements in physical metrics. I just want to say that we conducted a pilot study prior to this larger trial, and we actually saw very similar trends whereby in the pilot trial, which included only 74 individuals, but against the exact same population, all recruited from the falls prevention clinic, was that we found no significant benefits on physical function, but did see a significant reduction in falls, even within a small sample of 74 individuals. We also actually saw benefit for executive functions too in the pilot study. So our pilot results do support what we're observing in the larger trial. And I also want to flag that within sort of the original Otago exercise trials that was conducted by Claire Roberts and John Campbell, it was all of 4 trials, and they collectively demonstrated an overall falls reduction of 35%, but they also actually didn't see significant improvements in balance, and only small gains for lower extremity strength were observed. And so, I think these data do suggest that perhaps, exercise can reduce falls by other pathways other than by improving physical function. I also want to highlight that there are also studies out there that have been powered for falls, so they're well sampled to detect a reduction in falls if that effect truly exists. So these studies have shown significant gains in physical performance, but no reduction in falls. So just to highlight that, even though you can see changes in physical gains, that doesn't always translate in reductions to falls. And so then how do we make, how do we sort of decipher or process these findings? So one is, I think, when it comes to more frail older adults, or small gains or even just the maintenance of function in multiple domains, so cognitive, physical, could collectively contribute to falls reduction. And again, I want to highlight for the trial that we ran, we did include people who really technically were both cognitively and physically frail. And so it may be that, minor adjustments or minor changes, or even just simply the maintenance of their function could contribute to falls reduction. The other piece I want to highlight is that we know in a separate body of literature that exercise can impact neurosubstrates that contribute to mobility and falls. So as an example, we have previously shown that with resistance training, we could reduce white matter lesion progression, which again are associated with both cognitive impairment and with falls. So it could be that exercise impacts these neurocorrelates, but we actually typically in falls prevention trials do not include neuroimaging, so we can't really capture that effect. And so this is could potentially be one of the reasons we see what we see in terms of, benefits on falls reduction, but not so much on some of the physical performance metrics. And yet there's something that's kind of going in the background that we're just not measuring. And it could be these neuroimaging metrics that's typically not captured in falls prevention trials. So in summary, I just want to really, I think, emphasize that the current literature would suggest that when it comes to exercise and its role in falls prevention is not just about the physical aspects in terms of benefiting physical function, but also the benefits of exercise potentially on cognitive functions, specifically within the domain of executive functions, but also the benefits of exercise on both brain structure and brain function. I haven't really covered that extensively today, but certainly there's a huge body of literature that demonstrates that exercise do indeed have an impact on the brain, even in older ages and even among individuals with neurodegeneration or other chronic conditions. And so I'd like to move towards implications. So in terms of screening, one thing I would really like to convey is that when it comes to at-risk, I would love it if I could really get the message out there that when it comes to at-risk, really, in my opinion, and based on the literature, any individual, some degree of cognitive impairment should be viewed as being at risk for falls. And I want to emphasize, it's not about having dementia, but mild changes even within their cognitive abilities. And there's simple ways in probing that. So you could simply interview them and ask them if they have noticed changes in their thinking abilities, one. And the second question is if they're concerned about these changes. And typically, if people are responding saying yes to these answers, we would actually identify them as having subjective cognitive impairment. And so the key word is subjective, is not objectively measured, is really from the perspective of the individuals. But at the same time, they probably are the best judge of their capacities, right? We actually do know from literature that sometimes it's hard to objectively capture subtle changes in cognitive abilities, but actually better to interview the person or even those close to them. And really, they are much more sensitive to subtle changes than perhaps much of our standard neuropsychological testing. And having subjective cognitive impairment has been shown to be indicative of greater risk for developing cognitive impairment and potentially putting people at risk for falls. There's still more research to understand why that is, but there is value in asking people and potentially thinking about, whether there are truly changes within the context of their cognitive abilities. You can also think about screening for people for mild cognitive impairment. The Montreal Cognitive Assessment Tool is a simple screening test. It takes all of 15 minutes and has been shown to be a fairly sensitive screening tool for detecting mild cognitive impairment using a cutoff of 26 out of 30. There is online training that can be that you can do if you are interested. And certainly once you receive the training, you could obviously administer for life. And the MOCA is also free to individuals who are trained. The other piece in terms of screening and monitoring is to consider including measures of cognitive function. So these are more sort of the objective aspects of one's cognition. And I just want to highlight that it's been shown individuals with both impaired cognitive function and impaired mobility are simply at greater risk for falls and also functional decline as compared to individuals with only impaired mobility or only impaired cognitive function. Again, the MOCA is a nice screening tool if you choose to think about utilizing that in any capacity. But of course, I also think the digit symbol substitute test is very easy and highly feasible, and it takes all of 90 seconds. The only restriction about the DSST is it is a licensed tool, so you do need to buy the initial copies for that. But again, if you really are thinking about expanding your screening tools, I do think some components of cognitive function would be really helpful. Another aspect of cognition, but includes motor ability, is a dual task test, and there's many out there. So when I refer to dual task, I really am referring to a dual performance and motor and cognitive tasks together. And there's, again, a variety of tasks out there that you could use. So there is a dual task version for the time up and go, where someone carries a water jug. But to me, that's a motor and motor dual tasking versus a motor cognitive. And so one that I highly recommend is walking while talking. So you can ask people to do serial 7s as they do their usual gait speed test. And even if they simply just stop, so if they stop and during the test and to do the serial 7, that in itself is actually quite indicative of the fact that they're at greater risk for falls. And that's been shown through research as well. So it doesn't have to be where you're measuring them and trying to determine how they perform. The simple fact that they stop while trying to, walk and talk is a good indicator of risk. And then in terms of interventions, so throughout the presentation, I've embedded the notion that exercise can promote cognitive function and brain health. And so if we do really fundamentally think that central nervous system and its integrity plays a role in one's mobility and falls risk, then it would make sense to actually prescribe exercise from the perspective of promoting brain health, not simply from the perspective of reducing falls. And so when it comes to what we know about exercise and its benefits for the central nervous system, the most studied type of exercise is aerobic exercise of moderate intensity, and there's been a number of trials showing its benefits on both executive functions as well as brain structure and brain function. So thinking about potentially augmenting just moderate intensity exercise to individuals to reduce falls, but again, within the context of trying to promote central nervous system integrity. There's also lots of interest, both clinically and through research on exercises that cognitively load. So there's certainly people who think of, walking as a boring task, but I would, argue that that kind of depends on the individual. Walking is actually a higher order task, and as we get older, it does become more cognitively tasking. But regardless, if we again want to sort of tap into the CNS arm of falls prevention, it does make sense to think about developing exercise programs that are more cognitively challenging or novel. So certainly Tai Chi has come up as a mode of exercise that challenges individuals both physically and cognitively, because there's very specific sequences and motor patterns that are involved. Dance has come up quite a bit as well, although I would say I think that kind of depends on the individual you're working with. It could be too complex, so it has to be tailored to the individual. The third piece is sort of pairing cognitive training with exercise training. So not so much that they are done simultaneously like Tai Chi or dance, but more that you focus on providing cognitive training and then providing exercise training. What's debatable right now is the order of training, such that should cognitive training precede exercise training, or should it be the other way around? And there's a number of research studies trying to examine that. But preliminary evidence does suggest is that, if you do combine cognitive training with exercise training, there seems to be added benefit when it comes to both cognitive outcomes as well as mobility outcomes. And at this point, I just want to share a pretty interesting study that was published last year by a colleague of mine, so Joe Fergese, who's really a world leader in looking at sort of the interplay between cognition and mobility. And he actually conducted a fairly large randomized control trial looking at solely computerized cognitive training on improving walking in older adults age 70 years and older at high risk for mobility disability. And so this is really a trial really trying to sort of figure out if we simply tapped into the brain through cognitive training, could we translate benefits to one's mobility? And what they found is that while there was improvement in mobility, it wasn't significantly greater among the cognitive training group versus an active control. So what I take away from this is that when it comes to promoting mobility and falls prevention, exercise is key, and I think we can all agree with that. But potentially adding some cognitive loading or cognitive training would be beneficial, but not cognitive training alone. And at this point, I just want to end with some general recommendations. So this is not specific to high-risk individuals per se. And these general recommendations I want to acknowledge are drawn from a working group that I was in that was led by Stephen Lord, Kathy Sherrington, and Don Skilton. And we're all part of the World Falls Guideline Working Group. And our group was really tasked with summarizing the evidence for exercise. And so when it comes to components of exercise, it would appear that programs should include balance and functional exercises such as sit to stand and stepping. And I will highlight that these are included in the Otago exercise program for sure. And then the second piece is that programs should include multi-component aspects, so including balance as well as strength training, etc. And the last point is that when it comes to a sole form of exercise, Tai Chi is recommended with moderate certainty evidence. But to reap the benefits of exercise programs need to be of sufficient intensity and duration. And I promised Don Skilton to put this in, which is that programs really should be more than 12 weeks. There is I've lost track, but there is so many studies out there that are of 12 weeks that show benefits for what I would call surrogate measures of false risk or of on false risk, I guess is a better word, whereby after 12 weeks, we do see improvements in balance, improvements in SPVB, which are all great, but they don't necessarily, again, translate to reduction in falls. And hopefully I've emphasized that through the sharing of our own RCT results. And so the recommendations that they really should be more than 12 weeks to really impact on falls versus, again, false risk measures, which are more surrogate measures such as balance metrics and strength metrics. We also do fundamentally recommend that exercises should be progressive in nature so that you're always challenging both the physical system, but also the cognitive system, right? Because as you're progressing, whether it's balance or strength exercises, you're also educating the individuals and providing novel cognitive stimuli. So it's not just about the physical aspects of progression, but also the cognitive pieces as well. And the last point is adherence really does matter, and that shouldn't be surprising. But when you look at many of the exercise trials, and this is across the board, not just in relation to falls prevention, there's always the issue of lower adherence. And so when it comes to delivery exercise program, how we promote adherence should be a critical factor. And I will just highlight within the context of our own trial that I shared today, we, during the monthly phone calls, in addition to querying about falls and clarifying on circumstances of falls, we also always had a conversation about how they're doing with the exercise programming and having a conversation as to strategies to reduce barriers or to generate ideas as to facilitate their adherence. And so, and I think adherence strategies are particularly important for those individuals with cognitive impairment because many times they actually don't remember what you told them. And so having repeated messaging in various forms, verbal, handwritten, documented pictures, etc., is critical. For individuals who are physically frail, typically their threshold is not high. They typically fatigue easier. So again, it's about working with them to ensure that they can build the exercises into their sort of not only into their schedule, but also into their energy levels and sort of spans. So whether they're truncated throughout the day or throughout the week versus having that typical 3 sessions per week, it can also needs to be considered as well. And I do fundamentally believe because we had those conversations on a monthly basis, we actually observe adherence rates that were much higher than prior Otago exercise trials. So at this point, I'm just going to kind of revisit the learning objectives, which were these 3. Hopefully I have shared the information to address all 3 of them. Happy to answer any questions that you may have at this point. But before that, I just want to thank you for your attention. Also just to thank my lab for sort of all the great research they do. Really, I'm just kind of a facilitator. There's definitely the drivers of what we do. and to acknowledge everyone who's been in the lab, as well as the collaborators, and then just our funding agencies as well, which is listed across the slide. Thanks again.
Thanks so much, Teresa. I'm gonna share my screen now. There it is. Alrighty, so we do have some questions, really great questions that have come into the Q&A box. So if anyone has any remaining questions that they want to drop in there, please feel free to do so. But first, I'll just say another thank you, Teresa. We really appreciate you being here today with us, and such a fantastic presentation. All the evidence, but then also the implications. And so we're very happy to have your expertise today. So thank you. So I think we can jump into the Q&A now with the remaining time that we have left. Our first question is a bit of a question comment hybrid. It says, I wonder if there's a relationship specifically between flexibility, PROM, AROM exercises and fall prevention versus general exercise and fall prevention. I suspect that general flexibility, example in the trunk and hips, has a greater impact than is documented. In other words, consistent exercise that doesn't improve general flexibility would likely be less helpful for preventing falls versus exercise that also improves ROM and flexibility.
Yeah, that's a great question. And I have to admit, I never sort of have thought about that. But I guess in many ways are at least the exercise programs I have examined within our research program has always included range of motion exercises as well. So even for the Otago exercise program, it starts off with a variety of flexibility exercises for both upper body and the lower body. And yes, absolutely for the hip flexors and the knee and ankle as well. And so perhaps in many ways is incorporated, but I have not examined, I can't think of studies that have examined that specifically, but again, there are some studies that's coming out about yoga and falls reduction, and I believe that's conducted by the Sydney group, led by Stephen Lord.
Great, thank you. Alrighty, the second question is, for the 3 studies in the literature where exercise didn't lead to a reduction in falls, do we know if they used the Otago exercise program?
Yeah, so that's a great question. So I did take a look at those, and so no, not specifically. And I actually try to figure out if they also were progressive in nature, and I think that, and that's in part why in my slides I emphasize the progression piece. And so when I just actually reviewed all 3 yesterday, of course. And so no, they did not use the Otago exercise program specifically. One program did use I would say sounded very similar to the Otago, whereby they included balance and strength, strength training exercises. What was not clear across all 3 though, it was that whether they progress people over time, if that makes any sense. So for the Otago, they, if you look at their manual, it's definitely progressive in nature for all the components, both for the balance and both for the strength training. And I think that is key. We see that within the context of many other sort of studies of exercise as well, where progression over time seems to be quite critical in reaping the benefits.
Great, thank you. The next question has to do with cognitive stimulation. So they ask, is it possible that exercise gave people more confidence to go out and are exposed to more cognitive stimulation?
Yeah, no, and that's a really great question. That's something I actually was thinking about within, so I think so the short answer is yes, and then hopefully I can just take a second to expand on it within the context of my own sort of trial. So I do think so, in the sense that when we look at metrics of sort of community mobility, so we did also look at life space. So that's a questionnaire that queries people about sort of how much they move within their neighborhood and beyond. And it's typically labeled as the community mobility measure. And what we did see is that for people who are in the Otago exercise program, they seem to have a greater community mobility after the trial completion. And so that could in itself, as the I don't know who asked the question, as the individual suggested, that in itself could actually enrich the person on a daily basis, right? Because I think we all experience this if we stay at home because of COVID-19. There's not much stimulation or social engagement. But once you kind of get out and move about and just really interact, even within your neighborhood, there is a lot more cognitive, but also social stimulation, which I actually think also is really critical in all of our well-being, but also does feed into our cognitive health.
Perfect, thank you. The next question is kind of similar to a couple of other questions that are in the chat. So I'm going in the Q&A rather. So I'm going to try and collapse some of them. But the first question is that they might have missed the part, but in case other people have the same question, how long were they participating in an exercise program? For example, number of weeks or months. And a couple other people have asked about whether if once a week attendance in an exercise program is of any value. And then, there was another similar one. Oh, in general, it is mentioned about more than 12 weeks of a program, but how many days a week and for how long is recommended? So they're all kind of related. And if you need a reminder of what all those elements to that question were, just let me know, Teresa.
Sure. Yeah. So I'll try to remember. So in terms of like the studies themselves, generally they were 6 to 12 months. So for our trial, it was for 12 months. So even though the physio only went in for the 5 visits, which were banked in the first 6 months, I don't think I made that very clear. So all 5 visits were within the first 6 months. The participants were still to do the exercises from there onwards for the remaining 6 months. So it's like 12 months in total. And the Otago exercise trials were always designed to be that, so a 12-month duration. So I think that's the first question. And then second question is sort of, what's the minimal dose? And I think that's the question that's being asked. So I don't know if we really know that. That said, though, I think it's a roughly, like I would say, twice a week. And this is based on some of the work Kathy Sherrington has done within her meta-analyses. And we've also done within the context of our own trials, looking at sort of this minimal dosing perspective. So it kind of, I think two sessions probably is a fairly reasonable estimate as to having an effect. But, whether that's the precise answer, I think is still to be determined in terms of like the science, just because no one's really looked at dosing as a primary question, if that makes any sense. Much of the dosing answers has derived from like secondary analyses, looking at, what's the minimal dose, whereby then we see this in effect. And then I can't remember the third piece.
The third piece was
the 12 weeks.
Yeah, 12 weeks, but how many days a week and for how long? So you kind of touched on that so far.
Yeah, so I guess, again, just to emphasize, I think 12 weeks, I don't believe the evidence would suggest is sufficient for falls reduction. Certainly you see good improvements in all sort of the surrogate physical metrics. And typically these 12-week programs are usually 3 times per week is sort of is the general sort of protocol that you see within the literature. But I think my key messaging in that perspective, though, is that if you are looking in the literature and you see these 12-week programs, and sometimes the headlines are a bit deceiving, whereby it reduces false risk, but that's what it is. It's a false risk, whether that's measured by gait speed or measured by quad strength or measured by short physical performance battery. That does not necessarily translate to actual reduction in falls, and that's been sort of, I think, a bit of sore point with some of us, just because I think the messaging has sometimes been put out as that it is equivalent to reducing falls, but it's not.
Right. Alrighty. So we have more questions, but I think we only have time for one more, and maybe we can get some written answers to the outstanding questions. But this last question is great because it says, your Otago group were fairly high functioning. What are implications for long-term care or retirement patients?
Yeah, so yes, I guess it's all relative. I would say just first to start with the Otago exercise group, or the people in that trial, they were community dwelling. So yes, they are definitely higher function than those who are in long-term care. But if I saw them in the clinic, and I can attest, they really are, they were at that point, they're that group of older adults where one more kind of adverse health event would be putting them into either assisted living or long-term care. So I guess just to say, I don't know if they were necessarily, I would call high functioning, but they were, yes, community dwelling, and I think holding on by a thin thread. But for long-term care, I would say for the Otago exercise program, and we have done some of this work in BC, I think they need to be done. It can be modified because some of the most basic levels in the Otago exercise program is quite feasible. What needs to be done though is more the supervision piece. So I would not have them do it individually on their own. It would be supervised in a group-based manner, but lots of it could be done in the seated position. And Don, I even talked about some of the walking, which may not be that highly feasible nor safe, is that you can do things such as marching in the chair, could be sort of used to replace that quote 30-minute walk.
Right. All righty. Thank you so much, Teresa. It is 1 o'clock here in Ontario, so we're going to wrap up. But thank you, everyone who have left their questions in the Q&A box. We'll make note of them, and we'll try to get you answers for those in a timely manner. But thank you again, Teresa. Such a wonderful presentation, and we really appreciate your time. And I should mention that in the chat, there's tons of thank yous and praise for your presentation. So just wanted to let you know that.
Oh, thank you so much. I really appreciate everyone's attention.
Perfect. Thanks so much, everyone, and have a great rest of your day.
Bye. Take care.